Thank you to everyone who registered for our webinar this morning, Care Coordination, Improving Healthcare and Lowering Costs. My name is Nadine Israel, and I work with the Heartland Alliance for Human Needs and Human Rights as a Healthcare Policy Associate. I'll provide the introduction to today's webinar and moderate as well. Before we begin, I just want to take care of a few housekeeping issues. All attendees are in listen-only mode, and this webinar is being recorded. Also, attendees can ask their questions throughout the webinar using our chat feature. We will do our best to answer all questions at the end of the panelist presentation. Lastly, this webinar is brought to you by the Illinois Care Coordination Advocates Work Group, a group comprised of health, housing, and human service providers and advocates who are interested in educating stakeholders and lifting up the concept of care coordination, including the Illinois Healthcare and Family Services Care Coordination Innovations Project. If you are interested in learning more about this work group or participating in future care coordination advocacy efforts, please email me, Nadine Israel, at nisrael@heartlandalliance.org. We have an exciting lineup of panelists today presenting for us, including State Senator Heather Steans, Stephanie Luther, Senior Medical Director with Heartland Health Outreach, Mark Ishak, Chief Executive Officer with Threshold, Scott Dromek, Director of External Affairs with Northwestern Memorial Hospital, Denise Scarpelli, Chicago Market Pharmacy Director with Walgreens, and last but not least, Sarah Grabesh, Associate Director of Development and Evaluation with Heartland Human Care Services. I'll begin by providing a brief summary of care coordination, including the Illinois Department of Healthcare and Family Services, HFS, Care Coordination Innovations Project. Each panelist will then present on the role providers in their sector can play in innovations projects and the potential impact that sector can have on improving health outcomes and maintaining or lowering healthcare costs to the Illinois Medicaid program. Panelists will be speaking from the lens of the sector they are representing today. We'll also have time for questions and answers, which again we'll do our best to address towards the end of the webinar. Just as another quick reminder, you can submit your questions throughout the webinar using the chat feature. So before we start, we'd actually like to take a poll of the audience to just get a better sense of what sectors you all represent. So if you can please answer the next poll question. We'll just wait a few more minutes or seconds. Okay, so it looks like we've got 26% of the audience is a healthcare provider, so either primary healthcare, behavioral health, specialty healthcare. 5% are housing. We've got 43% are human services providers, and 24% advocates, and 2% is an elected official or staff. So you sort of have a wide variety of participants today. Okay. So as many of you may already know, the Illinois legislature passed a Medicaid reform law in 2011 that included a provision requiring that 50% of Medicaid clients be enrolled in a care coordination program by January 2015. The Care Coordination Innovations Project is one way HFS is implementing this provision of the law. In Illinois, care coordination will be provided to most Medicaid clients by managed care entities, a general term that will include newly created coordinated care entities, CCEs, and managed care community networks, MCCN, as well as traditional managed care organizations. Now, what is care coordination? Care coordination is a multifaceted process wherein a team takes responsibility for the care of an individual, coordinating medical and social support services across different providers and organizations. Care coordination involves communicating, networking, educating, and advocating for resources, and facilitating access to those resources, resulting in improved health and quality of life, as well as lower healthcare costs. Care coordination connects all aspects of an individual's healthcare needs, including primary, specialty, behavioral, and long-term care, hospitalization, human services and supports, and housing. It's important to keep in mind that the effects of care coordination would typically not be felt overnight, both in improved health outcomes and lowered healthcare costs. Rather, when coupled with comprehensive access to healthcare services and supports, the effects of care coordination can be felt over the long term. The Care Coordination Innovations Project will initially focus on the most complex, expensive clients in the Illinois Medicaid program. Now, these are seniors and adults with disabilities. While they only account for 16% of Medicaid clients, they utilize 55% of the Medicaid program's costs. The first phase of the Innovations Project calls for the creation of provider-organized networks of care through care coordination entities and managed care community networks. CCEs and MCCNs must have at least one hospital, one primary care provider, and one behavioral care provider, and that includes mental health and substance use services, participating in these new entities. In addition, non-traditional healthcare providers such as human service and housing providers are allowed and encouraged to partner with CCEs and MCCNs. And we're really excited to share that earlier this week, HFS announced the first round of Innovation Project Awards to 5 CCEs and 1 MCCN applicant. The 6 proposals selected by the state include 4 in northeastern Illinois and 2 in downstate Illinois. To learn more about the selected CCEs and MCCNs, please see the link for the Governor's Office press release in this slide. Now I'm going to turn it over to Senator Heather Steans. She'll give us her perspective on how Illinois legislators can impact the Care Coordination Innovations Projects and how lending their support to these projects can impact health outcomes of Medicaid patients and maintain or reduce costs in the Illinois Medicaid program. Senator Steans?
Thanks, Nadine. First, a little background in terms of why the legislature enacted care coordination. As a fee-for-service system, Illinois pays historically for quantity of care. This approach is fragmented, difficult to manage for clients, and incentivizes quantity of care over keeping people healthy, which has led to a very ineffective and wasteful spending. Illinois is one of the last major states to operate primarily as fee-for-service, with only about 2.5% of our Medicaid costs paid under a full risk-capitated managed care approach. The effect of the system is that our hospital readmissions rates for Medicaid patients are among the worst in the nation, and 45% of our Medicaid spending in Illinois is on inpatient hospital procedures compared to a national average of just 25%. There has been skepticism moving to managed care because of the tough history in Illinois with HMOs. Other states, however, have developed approaches to manage HMOs and different care kind of entities for real quality health care results as well as costs that are lowered, from which we can really learn. As Nadine mentioned, the Illinois legislature created the framework for care coordination when we passed and signed into law in January 2001, Public Act 96-1501. Senator Ryder and I had negotiated this bill with Julie Hamas, the director of HFS, the House, and the Governor's Office. And we did a couple of things in this bill. First, we required 50% of the Medicaid population to be in care coordination by January of 2015. At this point, we expect to enroll far beyond 50% of Medicaid recipients into managed care over time. While we may not get close to the 100% participation in rural areas, we expect close to 100% in Chicago and Collier counties. Second, we defined what services must be included in care coordination: primary care referrals, behavioral health, inpatient, outpatient hospital care, rehabilitation, and long-term care services. I want to note that we very intentionally did not include carve-outs for either certain populations or services, as many states have. We want to ensure a client's healthcare providers incentivized to obtain any and all needed services. Third, we also ensured that recipients will have a choice of systems and providers that will receive quality care which is culturally and linguistically appropriate and meets the diverse needs of people with mental health needs, disabilities, and seniors. We understand there was a bad history with HMOs and are committed to ensuring quality. There are also many models for service delivery available now, and we wanted to encourage this. This is why HFS is first focusing on the Innovations RFP, getting as many providers involved in creating what they will believe will be the best approach for them to provide quality care, and only then rolling out the RFPs for more traditional MCOs. Finally, the bill requires payments to be fully capitated or to use other risk-sharing structures. Simply having add-on fees for coordinating care is not sufficient in the long run. The care coordinating entities have to have skin in the game to be incentivized to keep patients healthy and ensure they get needed care. The bill requires HFS to report annually to the legislature on implementation of care coordination. The Legislative Medicaid Advisory Committee, or LMAC, is also continuing to meet and gets updates on implementation of the myriad Medicaid changes. The legislature can decide to revise the statutory framework for care coordination if needed, and in fact debated changes during the last session as we addressed the $2.7 billion underfunding problem of the Medicaid system. Given our belief that we'll get beyond the 50% of clients in care coordination, we considered putting this higher percentage into law and or moving up the deadline for it. But given how well implementation seems to be rolling out, we decided we didn't need to make that change at this point. The Care Coordination Innovations Project should provide a variety of models to best meet needs of clients. Results from these projects should provide data demonstrating whether or not the health outcomes are improved for clients and if costs for care have been impacted. I think legislators can help ensure the projects are evaluated to provide this critical information. The legislature will monitor implementation of care coordination, both innovations projects and their traditional HMO contracts, and can form views on what works best and under what circumstances. Results from the Innovations Project will help determine future direction of care coordination, such as what type of service delivery model should be expanded or contracted, what services should be included, and what payment or reimbursement methodologies work best. I also want to note that successful implementation of innovations projects can reduce the need for alternative Medicaid cost reduction. Medicaid costs are projected to keep rising far faster than inflation and state revenues. If care coordination is demonstrated to improve health outcomes and reduce costs, we will have less need to find other cost savings measures. The success of these projects can also help make the case for expanding the Medicaid population as envisioned under the federal health care reform law in 2014. Legislators who understand the benefits of innovative approaches will be critical to helping ensure we expand these models and make other regulatory changes that may be needed to support them. I want to close by stressing that this is a paradigm shift in healthcare delivery in Illinois. When we first passed the bill, I was bombarded with requests for carve-outs as provider groups were looking for ways to be excluded and not sort of change this approach. I believe over the last year and a half, mindset has been shifting as people understand this is our future and are now much more focused on how to do this well. I believe the Innovations RFP has really fueled this shift as a tremendous number and variety of organizations are forging new relationships to keep both Illinoisans healthier and bend the healthcare cost curve. I'm very excited to see the results from these new CCE and MCCN models over time.
Thanks so much, Senator Steans. Now I'm going to turn it over to Stephanie Luther. Stephanie is going to give us a sense of the role primary care providers can play in innovations projects and the potential impact their participation can have on the health outcomes of Medicaid clients and costs of the Medicaid program. But just before I turn it over, I'm going to ask Stephanie and the rest of our panelists to specifically address how their sector's participation in a CCE or MCCN, either as part of the care coordination team or just as a partner in that CCE or MCCN, would impact the patient's health outcomes and the health care costs he's incurring currently in the Medicaid program. This patient is a case study, and we're going to refer to him as John, and he is currently in a fee-for-service Medicaid program that isn't coordinated or integrated. So I'm just going to lay out the sort of John's history and a little bit of background, and then I'll turn it over to Stephanie. John is a 43-year-old African-American male. He's single and has a disability, so qualifies for and is on Medicaid right now. He's below 100% of the federal poverty level, has experienced periodic episodes of homelessness throughout his adult life, and is currently homeless right now. He suffers from severe depression and anxiety and is an alcoholic and has hypertension and diabetes. He also has sleep apnea, and according to his BMI, he is obese. John has missing teeth and hasn't seen a dentist in at least a few years. He is on average on 5 or more medications, though is not able to fill his prescriptions many times because he can't afford the copay. Therefore, John goes without his needed medications most of the time. He's currently unemployed and bounces between living in shelters, the streets, and hospitals. And with the hospitals, he's mainly being admitted to the emergency room, and also sometimes jail. He's been arrested several times in the past, all of which were misdemeanors where he served less than 30 days in Cook County Jail. All of these incidents were related to either public intoxication, noise disturbances, things like that. He has no family in the Chicago area, and he's mainly on the north side of Chicago. though he does have a few people he considers his friends who have also been experiencing homelessness for a while. We know about John because of his extensive use of Medicaid costs in the ERs, and because a community health worker in an FQHC, a federally qualified health center on the north side, has been working on developing a relationship with John for the past year or so. John will sometimes come into this FQHC to get treatment for things like a skin infection or chronic cough. Again, I'm going to ask all our panelists to address how providers in their sector would be able to impact John's health outcomes and his use of Medicaid dollars by partnering with a CCE or MCCN. So Stephanie, the floor is all yours.
Thanks, Nadine, and good morning, everyone. As a practicing physician, I'm really excited about this innovations project, as it will really change the way I am able to care for patients, and even more importantly, it will improve the health of our Medicaid population. And by definition, you can see primary care is the entry into any healthcare system and the medical home for each individual. And clearly, primary care is the necessary foundation. However, as Senator Steans said, our current American medical system is really favoring fee-for-service, and along with that, procedures and specialists and hospitalizations over primary care. As we know, the current life of a primary care provider now is to see as many patients as possible in those one-on-one appointments that are only 15 minutes long, because that's how we're paid. And while it makes sense to help our patients by phone or email or have other team members also care for the patients, the reality is it hasn't been getting paid. So even if it is the best work and the most integrated program, it just won't survive in today's fee-for-service world. And on top of that, I would say currently most of our primary care providers really do work in a fair amount of isolation from other healthcare providers, such as specialists, the behavioral health specialists, hospitals, skilled nursing, and such. And it's really the patient who's required to do the care coordination at this point. I see the practice of the future really as a team, and the question will be not how many patients can I squeeze in today, but rather what can we do as a team to make our panel of patients as healthy as possible. Imagine being in a system where all the different types of healthcare providers talked with one another, had a shared vision, had the same goals of quality and satisfaction, and that the reimbursement model supported that teamwork. This Care Coordination Innovations Project is here to change that dynamic to value-driven care rather than reimbursement-driven care. And we are creating more than just medical homes. We are now creating health neighborhoods to really get at the root of inequality and health disparities. And this is certainly why I went into healthcare, and not to feel like I was on that perpetual hamster wheel. And pretty soon, we'll have millions more Medicaid patients in this country who will need our medical homes and these health neighborhoods. And the Innovations Project is preparing us to be able to care for those most in need, to increase quality of care and decrease the overall costs, and especially those unnecessary costs in the system. As you can see, several studies have shown that primary care is associated with decreased hospitalizations and decreased costs of care. And adults with a primary care physician as their personal physician have 19% lower adjusted mortality. And I would say that's the best health outcome of all. So let's get back to John and how his life would be different in a CCE. It seems as John has been using the ER for his primary care and his urgent needs. In a CCE, he would have a better access to his primary care team who would know him well. He would get weekly phone calls from that team, and his community health worker would be working with him on the goals in his care plan. And this integrated care plan would actually be shared with all his healthcare providers, including behavioral health, case managers, housing services, and the hospital when he did need to be in the hospital. In the new system, these community partners would share data in real time. The primary care provider would know when John was in the ER at the time he was in the ER, and they would get the discharge summary the same day. And when seen in the ER, hospitalizations and redundant tests would be avoided because the ER would know that John had just had a cardiac workup done at his primary care's office. And in the CCE, John would be seen as a whole person. He would access medical and behavioral health services at the same site. He would see a dentist who would care for his teeth and gums, thereby controlling his sugars and preventing diabetic complications and early death. So as you can see, the Innovations Project is a real opportunity to create sensible and contracted relationships between different types of healthcare providers to really create the system to produce that better care at lower costs. And I would say primary care is at the heart of that system. And in fact, each project requires primary care, whether that's a private physician or a community health center or an employed physician group. And actually, we need all of you to make a difference and build our future healthcare system in a way that makes sense to us and especially makes sense to our consumers.
Thanks, Stephanie. Now I'm going to turn it over to Mark Ishak, and he's going to give us a better perspective from the behavioral health sector viewpoint. Mark?
Great. Thank you so much, Nadine, and good morning, everyone. Like Senator Steans and Dr. Luther just before me, and I hope those following me, I have drunk the care coordination Kool-Aid. We have a unique opportunity before us to change the healthcare delivery system in Illinois, and most importantly, to change the lives of the most vulnerable among us, including those affected by mental illness and substance use. I'm going to start out with a few definitions and some context to set the stage. What is behavioral health? It's a confusing term to many, to be sure. According to SAMHSA, the Substance Abuse and Mental Health Services Administration, behavioral health is a general term that encompasses three things: the promotion of emotional health, 2, the prevention of mental illness and substance use disorders, and 3, treatment and services for substance abuse, addiction, and mental illness. It's my contention, based on boots-on-the-ground experience, evidence, and a growing body of research, that care coordination will enhance health promotion. It will prevent illness and disease, and it will lead to better treatment and better health outcomes. And we all know that in behavioral health, in substance abuse and mental health, treatment works. So why is there such a focus on mental illness and substance use in care coordination and the development of these new provider-led care coordination entities? It's because millions of people with behavioral health challenges are suffering, dying way too early, and costing the system a small fortune. 1 in 4 adults suffer from mental illness. 10% of all children struggle with a mental illness. And people with severe mental illnesses die 25 years younger than the rest of the population, typically because of untreated or undertreated medical conditions, such as cardiovascular disease, pulmonary disease, diabetes, and the like. 25 years younger. This is not okay. In terms of substance use and abuse, nearly 23 million people use illegal drugs, and millions more are addicted to legal, i.e. alcohol, and other prescription drugs. 90% of people who need substance abuse treatment and care simply cannot get it. And millions of people with a severe mental illness have co-occurring substance use disorders and other chronic medical conditions. These costs, both financial and human, are staggeringly high. The direct and indirect cost of mental illness in Illinois is more than $2.6 billion. And the cost of substance abuse is even greater. The human cost is beyond quantification. Unnecessary disability, unemployment and underemployment, school dropout, homelessness, incarceration, suicide, and individuals, families, and communities torn asunder. So this all sounds really sad, but there is hope. There's great hope. I have huge hope in care coordination. I have huge hope in the 6 innovation care coordination entities that were just announced by HFS this week, and huge hope in Medicaid expansion that will provide insurance, if not immediate access, for more than 500,000 people here in Illinois who have heretofore been denied coverage. Today in Chicago and throughout the state, we are literally creating coordinated care systems for the Medicaid population in Illinois. Behavioral health providers, community health centers, outreach mental health providers, substance abuse organizations are key. Did I say that enough? We as behavioral health providers, you behavioral health providers out there, in collaboration with our medical, housing, hospital, social service sisters and brothers, will ensure that people get the right care at the right time at the right place to improve their health outcomes, to reduce hospitalizations and ER use, and yes, to save money. We have to be at the table, and in some instances we have to be leading the way as behavioral health care providers, because persons with severe mental illness and comorbid conditions are hospitalized and use the ER twice as often twice as often as persons without mental illness. In our case study, John is in and out of the hospital in the emergency rooms. But with strong coordinated care, John's major severe depression and comorbid conditions will be treated in an appropriate setting, such as a community health center, a community mental health center, an outreach substance abuse and mental health team, rather than waiting until his conditions are exacerbated and using the ER for his regular care. In Illinois, there are hundreds of thousands of people like John, unfortunately, with behavioral health and related conditions and challenges who are homeless, poor, and cycling in and out of the hospital's ERs and often prisons and jails. And behavioral health care providers, you, are key to changing that story. And we have to help the whole system of medical and social service providers better understand our populations and make decisions in partnership with us and our collective clients on their optimal care. And we can do this. Many of us, many of you online, have done this already. There are model programs in Chicago and throughout the state where primary care providers and behavioral health care providers are integrating services and staffing and ensuring that their shared patients have lowered their blood pressure, have lowered their cholesterol, have lowered their glucose levels, and have reduced their weight if they're suffering from diabetes. And yes, at the same time, have managed well and in many cases improved their mental health and wellness. So thank you all so much for helping us create a healthier healthcare system and a better future for our patients and our communities.
Well, thanks so much, Mark, for that thorough and impassioned presentation. Now I'm going to turn it over to our fourth panelist, Scott Jomek, who I'm hopefully pronouncing his last name correctly. He's going to provide us with a hospital's perspective on care coordination and the Innovation Project.
Thank you, Nadine. Good morning, everybody. I was asked to provide the perspective of a hospital with respect to care coordination. And one of the thoughts I wanted to convey is that hospitals and health systems throughout Illinois are essential to making care coordination effective throughout the state. Hospitals serve diverse communities with diverse needs, not only in the Chicago region, but also throughout the state. Hospitals also, to give you another example, help provide the backbone for the state of Illinois' healthcare delivery system. The hospital community has partnered with the Illinois General Assembly, for example, to bring significant additional federal funding for the state Medicaid program through the hospital assessment program. This funding also benefits non-hospital providers. And hospitals also support and really have the same goal as the General Assembly and HFS with respect to care coordination, and that is successfully transitioning to improve models of care for patients based on the goals of better outcomes, improved access to quality care, and also being good stewards of the public resources. Hospitals believe that care coordination should focus on the entire spectrum of a patient's needs. Effective care coordination can certainly reduce hospitalizations, lower the rate of complications from chronic conditions, and also help address and eliminate health disparities. Reducing overutilization and avoidable utilization of healthcare services also provides an opportunity for cost savings, and that's a key component, we believe, of care coordination. Another key factor that needs to be taken into account is data analysis, testing, and measurement. These are really key, and it allow us collectively to identify the health risks of the Medicaid population, which need to be really fully understood in order to determine what strategies will work over time. And of course, I think we would all agree that payment systems must be incentivize care coordination and care management. Flexibility is another key for both care coordination and financial risk as well. The key is to really recognize that what may work in one community may not necessarily work in another community. The goal of a care coordinated system should really ensure that there's access to primary and preventive care, avoid unnecessary utilization of the emergency department, and to avoid preventable readmissions as an example of that, and ultimately to have a streamlined referral and access process. We also think that HIT systems must be able to talk and to be able to share data records, and the ability of the state to succeed in its development and implementation of a health information exchange will likely be very important as part of care coordination as well. And ultimately, when we look at the expanding of the Medicaid program here in Illinois pursuant to the Affordable Care Act, Care coordination is going to, we fully support that, and care coordination is going to play a very important role in that effort. With a successful CCE program, we'll make sure that the expanded populations will be in the right care at the right time and in the right setting. Ultimately, regarding our patient John, just a couple of notes. Northwestern Memorial Hospital is able to provide currently a high level of care to patients such as John, largely through our existing and long-time relationships with area federally qualified health centers, through our follow-up care clinic, and through other programs and relationships that we have on campus. But CCE and MCCN offer additional enhanced opportunities to really build on what's currently in place. Creating new partnerships with community-based service providers and others can help ensure that John has a true medical home, has access to primary and preventative care, effectively reduces his use of the hospital emergency department, appropriately uses other hospital resources in coordination with his primary care physician, and also by linking and making sure that John is working with the appropriate social service organizations to address his personal and socioeconomic issues that impact negatively, of course, his own personal health status. Thank you for the opportunity to present today.
Thanks so much, Scott. I'm now going to turn it over to Denise Cartelli, and she's going to give us a sense of how pharmacies can play a role in innovations projects and also impact health outcomes and costs in the Medicaid program. Denise?
Thanks, Nadine. Pharmacy can play a big role in care coordination projects. Pharmacists can be an extension of care on many levels. Patients usually visit their pharmacies about 12 times a year compared to a few visits a year to their physician. Some services a pharmacist can provide within care coordination programs are adherence and counseling, medication therapy management, also known as MTM, medication reconciliation, immunizations, health testing, and transition of care programs. Adherence and MTM programs can be key in providing positive patient care outcomes. With adherence, the pharmacist can educate the patient on the importance of taking their medications, as well as inform the physician of any patient that is non-adherent for whatever reason. MTM can help identify any duplicate or an unnecessary medication the patient is on, and also discover any adverse effects the patient might be having. So you may be wondering why adherence and MTM programs would be important in a care coordination program. Well, let's look at prescriptions on a national average. If an average provider writes 100 scripts, on average, only 50 to 60 of those scripts make it to the pharmacy. Those that actually get filled, only 45 to 55 of those prescriptions are picked up by the patient. Then only about 25 to 30 of those prescriptions are actually taken properly as prescribed. And about 15 to 20 of those are actually refilled as prescribed. If you can imagine, these statistics will likely be even more alarming for many Medicaid patients since they are faced with many more barriers, such as homelessness and poverty, that make it that much difficult and sometimes near impossible to adhere to their prescribed medication therapy. Another service that can be provided is medication reconciliation, which is beneficial to hospitals and physicians to identify what the patient is on and if there's any drug duplication or drug-drug interaction. Pharmacies also have many transitional care programs that can be incorporated into the medical home to help improve outcomes and be a health partner with physicians and hospitals. Many pharmacies also have clinics within their pharmacies that are staffed by nurse practitioners. They also play a piece in care coordination. They can be part of ER diversion, support for care plans in the community, and gap reduction. Both the pharmacies and the clinics have the ability to report the care given to a patient back to the physician or other health care providers to be kept in their medical charts. There are many different programs pharmacies can offer to help Medicaid patients have improved health outcomes and maintain and reduce costs in the Illinois Medicaid program. Some of the programs offered during care gaps are health screenings, such as A1C and blood pressure checks, drug dose monitoring, immunizations like flu and pneumonia shots, adherence programs, and these conversations can be reported back to the providers, and assistance in enrolling patients into programs that will help cover their medications or copays. There are many patient assistance programs available that help cover high-cost medications that patients are not aware of. Many pharmacies also offer clinical programs around end-of-life, chronic kidney disease, diabetes, HIV, hepatitis C, and transplant. These programs provided by pharmacies help the patient manage their disease within the community and be a resource for the patient. Some of these programs are offered in group educational sessions, which also help patients connect to their other patients like them within their community. Some other programs offered to help improve outcomes and reduce overall costs of the system are care transition programs, which help patients transition from the hospital to home, med gap analysis, which are reports that identify when a patient is not adhering to their treatment plan, and ready dose, which is a special packaging or unit dose packaging for patients that have difficulty remembering when to take their medications or manage all their medications they are on. This packaging really helps improve adherence, and we all know any way to improve adherence can result in improved healthcare outcomes. So after hearing everything a pharmacy can provide, let's look at the patient John. John isn't adhering, also known as non-compliant, to his prescribed medications due to many factors, such as cost and his living situation. In today's Medicaid system, John will keep visiting the ER when he's having complications with his medical conditions. The hospital will get him stable, and he will go back out to the community and continue to be non-compliant. The hospital may be unaware that he is not taking his medication or is unable to provide the follow-up to make sure he is taking his medications. However, if John were in a CCE or MCCN and received coordinated care, the goal is that his care will improve and his costs will be stabilized. The pharmacist will receive the scripts from the ER. If John came into the pharmacy to pick up his scripts, the pharmacist could then do some education with John on the importance of adherence to his medication. Also, since John likely cannot afford the medications, the pharmacist would help him get the co-pays covered by enrolling him in a patient assistance program. If John never picked up the medication or refills, the pharmacist will try to contact John's primary care provider and or the care coordination team. In this way, the pharmacist will be a resource for John as a community beyond just a provider who fills his prescriptions. As you can see, there are many ways the pharmacy can help in care coordination projects to help improve patient health outcomes and reduce or maintain overall healthcare costs. Thank you.
Thanks so much, Denise. That was a really helpful overview of how a pharmacy can play a role in care coordination programs. I just want to remind the audience that you can use the chat feature to plug in some questions that you may have, and we'll address those at the end of the panel's presentations. Now I'm going to turn it over to Sarah, and she is going to give us the housing and human services sector's perspective on care coordination and the opportunities for these sectors within the Innovations Project. Yeah?
Thanks, Nadine. I'd like to start by giving a brief overview of what I will be discussing when I refer to supportive housing and human service providers. Permanent supportive housing serves individuals who are experiencing homelessness or at risk of homelessness, persons with disabilities, and those who benefit from supportive services to maintain their housing. Permanent supportive housing includes both access to housing as well as ongoing supportive services. Permanent supportive housing programs, also known as PSH, as well as human service programs, may target services to populations with a variety of complex needs, including but not limited to individuals experiencing homelessness, survivors of violence, individuals who are at risk of contracting HIV or sexually transmitted infections, people who are low income or receive mainstream benefits including TANF, LINK, and SSI or SSDI, individuals who are unemployed or underemployed, who are living with chronic medical conditions including HIV, chemical dependency, and mental illness, individuals with criminal backgrounds, veterans, seniors, and youth. As Medicaid eligibility will shift to cover all persons below 133% of the federal poverty line in 2014, the vast majority of individuals utilizing permanent supportive housing and many other human services will become eligible for Medicaid if they are not already. Supportive housing providers generally have the following goals in regards to their services. that they increase skills to maintain housing stability, develop skills to manage complex and chronic medical conditions, including chemical dependency and mental illness, provide linkage to and coordination of other needed services, and develop employment and asset development skills, as well as provide crisis intervention as needed. The goals of human service providers vary widely depending on the type of provider, but all focus on providing services to increase the stability of the person served. As you can see on this slide, a variety of services provided by both housing and human service providers would be beneficial in a care coordination model. First and foremost, PSH providers work to link participants to safe and affordable housing or to stabilize their current housing situation. It is going to be very difficult for someone who is experiencing homelessness or a housing crisis to focus on other needs related to their health, their income and benefits, and community support without first having a stable place to live. When thinking of our case study patient, John, a community health worker that is part of the care coordination team may refer John to a permanent supportive housing provider who will work to link John to permanent housing. Once John is linked to permanent housing, he will have a safe and stable place to live with reduced environmental risks, increased safety, and a solid foundation to develop goals around his other identified needs, including his health care needs. Secondly, PSH and human service agencies provide case management services to link individuals to other services in the community that meet their needs and to coordinate with these entities to ensure continuity of care. This could mean linking someone to a healthcare provider and ensuring that they have access to transportation to get to their appointments. Another example may be completing a screening to see what benefits someone may be eligible for and then assisting with an application for those benefits. And that way as well, PSH and human service providers can serve as a point of access for enrollment in Medicaid, particularly with the knowledge that there will be an influx of individuals who are eligible for Medicaid based on the new eligibility rules beginning in 2014. John's case manager will work to link John to relevant services to meet his needs, including a primary care provider, medication discount programs, dental services, and a behavioral health provider as needed. The case manager, who may be a part of the care coordination team, will work with John to ensure access and transportation to these services, to provide ongoing collaboration and advocacy with providers to ensure continuity of care, and to provide landlord advocacy and tenant education to promote housing stability and prevent recidivism into homelessness. PSH and human service providers also provide services that are home-based or focused in the community where the participant lives, which increases access to these services. Services are provided from a holistic perspective based on the participant's needs. John's case manager may also provide support in regards to building a community support system for John through linking him to local community resources based on his needs. This could include a variety of resources, including other social service agencies, support groups, food pantries, the alderman's office, or the local DHS office. Supportive housing has been demonstrated as an effective model to serve individuals with complex needs who are experiencing homelessness or at risk of homelessness, have a disability, and require supportive services to maintain housing. Many research studies have shown that the provision of permanent housing and supportive services reduces recidivism into homelessness, improves overall health, and improves mental health and substance use outcomes. In addition to housing and supportive services, housing providers can also provide housing location and inspection services, which decreases the risk of adverse health outcomes due to risk factors in the home. Tenant education and landlord advocacy also reduces the risk of eviction and recidivism into homelessness, all of which has a clear connection to one's health. Evidence also suggests that a reduction in Medicaid reimbursed services after individuals experiencing homelessness were linked to permanent supportive housing, not to mention the reduced strain on other systems, including emergency shelters and the criminal justice system. Lastly, human service providers work with participants to maintain their health, to be linked to all services for which they are eligible, and to provide wraparound supportive services based on the participant's needs. Great.
Thanks so much, Sarah, for rounding us out today. We've included this slide as a resource to help you learn more about the HSS Care Coordination Innovations Project. So that's the first link on there, the 2011 Medicaid Reform Law, and further reading about care coordination and just integrated care delivery systems in general. I'm going to now open it up to the audience for questions. Again, feel free to type in your questions using the chat feature, and we'll do our best to answer them. We've got a few questions right now, so I'm going to look through these really quickly. Let's see. So the first question we have is asking about adult dental. So adult dental coverage could help the state reduce healthcare costs down the road, and many people who have chronic conditions take many prescriptions that have side effects causing damage to their teeth, which can then lead to infection and high costs. The question is, how can dental play a role in coordinated care entities or managed care community networks? So I'm going to open it up to the panelists, and feel free to jump in if you have a thought on this.
This is Stephanie, and this is a fabulous question because I think it's a really good highlight of what's not been working in our system, both on a fee-for-service level and frankly because the overall cost of the system has gotten out of control. We've had to cut back in areas, and this has really taken a hit in the last couple of years, and we're definitely all feeling it. I think what's really different here and going forward with these CCEs and the MCCNs is that change in the payment structure. So now there is going to be a more push for payment based on outcome. So does John with diabetes do better, and you will then get paid as the organization. And I can give him all the insulin in the world, and he may not do well until he gets his teeth and gums taken care of. So the savings of him not being hospitalized and the savings that is incurred by the organization can then be put into the resources where we know it needs to be put in, such as dental. So thanks. Great question.
Does anybody else have any thoughts or anything to add? Okay, great. Our other question I was going to direct to Stephanie, but then anybody else can sort of also jump in. What is the communications method with care coordination? And how will all the players access John's medical history? Essentially, how is this data going to be preserved?
Right, and gosh, you guys are really good on the ball here with questions. So I think for this, I think the main point is that we all have to agree to communicate with each other. And I know as a practicing physician, sometimes that falls of I'm waiting for a fax to come in, or maybe I should just pick up the phone and call somebody. So the actual organization will be putting in policies and procedures so that we can make this happen. And what's fabulous is in 2012, we have so many more options with data and with communication. So I think, we're definitely, as Mark said, drinking the Kool-Aid, and so we've been doing some good dreaming to actually have, HIPAA compliant, very safe software to be able to do a lot of this communication, so it isn't based in the faxes and the phone calls that tend to get lost often. And then I think we're really relying on data so that it may not wait for the patient to go see a specialist, but the data coordinator part of the organization will already know that John needs to be getting out to see his specialist or get his preventative health care done. So I think this is really part of a new healthcare system relying on new age equipment, like all these fancy smartphones and software. So that's my take on it.
Does any other panelists want to jump in? Okay, great.
I think the only thing I want to add, and I think Stephanie and maybe everybody used this word about paradigm shift. I mean, I can't sort of restate that enough. And thinking about this as we've been planning for coordinated care entities and helping each other write applications, it's such a different focus in the future. It's so much less on my institution or my organization or my service as opposed to what are the array of services that need to be provided in community settings. It's going to force all of us to work together in a different way, to open up our books, to open up our records, to open up our electronic data. and to be honest about what our capacity is, what we do well, what we don't need to be doing anymore, how we need to partner. So yeah, I think Heather absolutely said it in her opening remarks that this is a revolution in the system, and we all have to fasten our seatbelts.
Another quick question that we have is, how can an organization join in the 6 chosen CCEs or MCCNs? I actually wanted to quickly sort of address this one. So if you click on the link in the slides, once sort of they're posted, you'll be able to access a press release that lists out who the organizations are and sort of what they're about, where they're going to be. But HFS on their care coordination microsite, part of their website, has a matchmaking feature on the right-hand side of the page. And what that feature was meant was for both applicants, so lead applicants, and partners to put in their information if they're sort of seeking each other. So if you're a lead applicant on a CCE proposal, you would put in your information and sort of put out who you're seeking. You're seeking human service providers, you're seeking hospital partners, and sort of what region you're looking for, who you serve, things of that nature. And vice versa, if you're looking to partner with somebody, you can use that feature on the website to input your information. So I know that's one way to try to get at how to sort of figure out how to partner with these initial selected organizations. Another point I wanted to put in on this is that we know that these proposals are sort of rolling awards. So the HFS has said that they haven't put out a timeline yet, but we know that there'll be more awards coming down the line over the next few months or so. So I don't know if anybody else.
Yeah, I want to just kick in on this. This is Heather Steans. There is going to be further care coordination. This is sort of the first step. There's already a dual eligible ones out there right now for people who are both eligible for Medicare and Medicaid that's out. Then for these care coordinating, these innovations, there were some folks who weren't awarded right now, but the department is going to be working with them to restructure proposals and give feedback on it, and there'll be another one as early as April in 2013, another round of the innovation. So you can either still try to partner with the current one, or there's going to be an opportunity to join a new one, and there'll be another round coming out. You know, the goal is April 2013. It may get pushed back a little, but there is going to be one. Finally, there's also going to be a more traditional RFP put out there for more traditional HMOs for other parts of the population as well, kids and whatnot. So this really is, we're doing a multifaceted approach in this.
Thanks, Heather. Another question that we had, I'm going to throw it out for anybody to answer out of the panelists. How would Medicaid skilled care residents be impacted by the sort of creation of these coordinated care entities and managed care community networks?
Okay, this is Heather Steans, and other people should pipe in on this. It is truly sort of my hope that through the these new care coordinating entities, MCCNs, the various approaches, that's where the decision is going to be made, and with the client, of course, first and foremost, deciding where it is they want to be getting care. So is it in a home and community-based setting? Is it in a long-term care institution? I think that flexibility is going to be there a lot more to get the best kind of care in the right kind of spot. And I would envision that this is going to then shift people more into home and community-based settings and out of institutions more naturally and hopefully more quickly than the state's been doing historically. So, you know, that certainly is part of how I would envision this working, and I'd love other people to jump in on that.
Any other thoughts on this?
Yeah, this is Mark. Yeah, I mean, we're working on this issue as we speak. And I mean, I think that the Williams, for people that are familiar with the Williams consent decree about moving people out of institutes of mental disease, and the Colbert decree of moving people with disabilities and severe mental illnesses out of nursing homes, which is going to start up probably in November. I mean, these are some sort of good working examples of the systems change already in progress. And my hope is that the lessons learned from Money Follows the Person, from a 1.5-year implementation of Williams and the beginning implementation of Colbert, that will help us address some of these issues of both transition, and deep coordination with those entities as well, because it's not sort of an us versus them or institution versus community care. It's about the patient and finding the right place at the right time with the right services and to meet his or her needs, with an ultimate goal of creating, as Sarah and others said, an environment where people can live healthy in their community, in the neighborhood that they choose, in the housing that they choose with support services. And I think that the movement at the state through the consent decrees and the creation of these both CCEs and MCCNs will get us to that point.
Great. Thanks, Mark. We have a few more minutes, so we'll just keep going with these questions. Next one is, in Illinois, fee-for-service environment, human service providers have stopped or curtailed providing some services to clients because they aren't getting reimbursed. Is coordinated care an opportunity to build back system capacities that have been lost over time? I'm just going to throw that out there.
That is the dream. And I'll only say it for a second because a lot of people that can address it, but that is absolutely the dream. You know, for the first couple of years of these CCEs, it's not business as usual, but it is fee-for-service as usual. And I think it's important that people understand that we're going to be billing Medicaid as we bill Medicaid. If it's under Rule 132, if you're a behavioral health provider, or the other many rules that people, and many complicated rules that people bill under. But yeah, the hope is to build up the system so that we can provide the kind of services that are not paid for by Medicaid right now, but hopefully through reduction in costs in inappropriate care, overutilization of inappropriate care, and expensive care, that we're going to be able to put those cost savings back into the very things that we're not paying for now because we either lost capacity dollars or because Medicaid doesn't pay for it, including housing and supportive housing and case management and dental. So yes, that is the dream, and our goal is to turn that dream into a reality.
Great, and I agree. This is Stephanie, and I think the paradigm shift here is an example of we now consider housing as health care, for example. These are not separate entities anymore. And I'll tell you, there's 3 patients in our practice who had horribly hard to control diabetes, mental health issues, the blood pressure. Once we got them into the supportive housing, it was freaky. We actually weaned them off their medicines. I've never actually taken people off blood pressure and diabetes medicines before, and really kept them out of the hospital. So that is the paradigm shift. And yeah, it's going to take us a little while to get there. It's not tomorrow, but we're getting there. This is much farther than we've been in decades.
And this is Heather. Wearing my appropriations chair hat, absolutely that's the hope and goal. And it also, I think, puts front and center what the actual needs of the clients are, that's driving what they're getting, not what funding is available.
Yep.
And I just think that is totally key in making this work, and why I think it really, as I think Stephanie had referred to it, value-driven as opposed to, you know, what fee-for-service is available there, driven kind of provision of care to the client.
So we still have a few more questions, but we're sort of running out of time. So what we're going to do is we're actually going to reach out to those folks who we didn't get a chance to answer their questions, and hopefully be able to provide an answer. I just wanted to wrap up really quickly. There was one last question about next steps for CCE efforts, like other populations, children with complex healthcare needs. And HFS has said that they're sort of rolling this out again in phases, and that children with complex healthcare needs are sort of the next phase in terms of the RFP process. So just sort of keep posted. I think their website is a good place to start to get a better sense of where they're at and how they're rolling. I just want to quickly thank our panelists for providing a really sort of comprehensive overview of coordinated care and the HFS Care Coordination Innovations Project. And thanks to the audience for great questions and for participating today. So we're now, don't forget to fill out a survey at the end of the webinar. So right when you click off, fill out a survey, 30 seconds. That would be really helpful. Thanks so much, and have a wonderful rest of the day.